right. Welcome again. Now we have the pleasure of hearing from Dr. N. Jim Rhodes, uh, an esteemed pharmacist and associate professor at Midwestern University, specializing in infectious disease pharmacotherapy and clinical pharmacokinetics. Dr. Rhodes holds a Doctor of Pharmacy degree from the University of Florida and a Master of Science in Clinical Investigations from Northwestern University. He's a key figure at the Midwestern University Pharmacometrics Center of Excellence and serves as Fellowship Director at the College of Pharmacy. His groundbreaking work includes the development of a user interface for the optimal data analysis, non-parametric machine learning algorithm. Currently engaged in clinical translational research, Dr. Rhodes is also active in infectious disease organizations and contributes significantly to continuing education in clinical pharmacy specialties. Unfortunately, Dr. Rhodes could not be here in person with us today. So without further ado, let's delve into his recorded talk on leveraging sparse data to define beta-lactam PK/PD in hospitalized patients with pneumonia.
All right, without further ado. Hello, thank you for inviting me to be a part of your symposium this year at IU and the CTSA, Disease and Therapeutic Response Modeling Symposium. I'm very pleased to be a part of this wonderful discussion. Today, what I wanted to speak with you about is leveraging sparse data to define beta-lactam PK/PD in hospitalized patients with pneumonia. This is a project that stems from a few of our NIH studies that we are working on in collaboration with Northwestern University, as well as collaborators out of University of California as well. My college is the College of Pharmacy at Midwestern University. I also practice as an ID pharmacist at Northwestern Memorial Hospital, as you may have heard. Today we're going to focus on some of the modeling work that's been done as part of this NIH study. There we are. My only disclosure related to this presentation is some consulting work done unrelated to the current discussion. So when it comes to beta-lactams, as many of you likely know, these are small molecule antibiotics that we use very often from anything from simple upper respiratory tract infection, strep throat, all the way through life-threatening sepsis in critically ill patients. So we're really spanning the spectrum. And really the focus that we have here is on infections that are very difficult to treat, serious and life-threatening infections such as hospital and ventilator-associated pneumonia. But what lessons can we garner from some of the earliest work that was done that exploring the pharmacology of these agents? If we turn back the clock and look at some of the early work done by Harry Eagle as well as others, what we see is effective beta-lactam concentrations arrested bacterial replication. So that was really the first sign that these were potentially effective therapeutics with broad activity. Another interesting insight that was garnered was that the time to bacterial recovery was frequently greater in vivo versus in vitro. Again, suggesting that there was a role above and beyond maybe necessarily the antibiotic itself. As we moved from an in vitro system into an animal model or in patients even, in patient samples, we see that there is potentially, again, a role of the immune system, which I think impacts certainly our pharmacology and our need for thinking about how we use these agents. They also observed that sub-inhibitory concentrations resulted in the need for a longer course of treatment. So we really needed to treat for a longer period of time unless we got the concentrations right up front. Likewise, if we achieve concentrations above a critical value, then for some strains there was less efficacy noted, which was an interesting finding and sort of the origin of the Eagle effect and why that might be the case. I think is an area of interesting exploration. And certainly, I think what we see clinically is that if we get concentrations too high in patients, we can have deleterious effects in terms of toxicity among other things. And then again, high early log kill reduces the need for more frequent dosing. So getting the exposure right on the front end is a huge important part when we're translating from some of these early studies into what has become more or less a standard practice. So, when we think about beta-lactam therapeutics, usually we are not typically talking about therapeutic drug monitoring. At least in the last, I would say 80 years, it hasn't necessarily been at the forefront of our practice. These agents are widely regarded as highly safe with fairly predictable pharmacokinetics. And so by and large, it has been sort of overlooked in terms of the need for therapeutic drug monitoring. And when we look at rationales for therapeutic drug monitoring, such as narrow therapeutic index, established exposure response, or exposure toxicity windows, we start to wonder, what aspects of beta-lactams fall into those criteria. And certainly, as we start to push our doses higher and higher to treat some of these more difficult to treat pathogens with higher MICs, or we think about our altered pharmacokinetic states, potentially things like augmented renal clearance, where patients are clearing drug rapidly, we push our doses. Do we potentially move into this realm of excessive and potentially harmful concentrations? Whereas, again, in a number of patients, upwards of 40 to 60% of individuals, are we underdosing them and maintaining concentrations less than 100% time above MIC, maybe allowing, as was seen in those early pharmacology studies, regrowth of organism and predisposing to the need for longer courses of treatment with less overall efficacy. So perhaps this is, again, a lesson that we can garner from some of the early pharmacology work done in this space, that there is maybe an effective window for beta-lactams. Maintaining concentrations between 1 and 4 times the MIC is really where we start to see maximal killing and most of our bacterial efficacy. And then translating this, I think, to patients has become the next frontier in terms of how do we actually define that for our patients. So someone once said, what is the bottom line? Put the bottom line up front. And then I mentioned that 40 to 60% of our ICU patients will fail to achieve these goals. If we accept that 100% time above MIC is where we should be with our therapeutics, even upwards of 4 times the MIC, then we're not achieving this in a significant number of our individuals. So this is a picture of not of Jason Roberts, but I think that's the bottom line because Stone Cold said so, right? So who should we be considering monitoring beta-lactams? If this is sort of the emerging paradigm and we need to start thinking about this clinically, who should we be thinking about it for? Well, certainly I think the ICU patient population, both adult and pediatric, as well as neonatal ICU, is a population that has high inter-individual variability in drug exposure. What we see in the package insert and what we see with our population models in terms of mean trends may not really truly reflect the individual in front of us. And so what do we need to consider when we're looking at that individual? I think certainly changes in the infection site concentrations. So for some individuals, that might be the lung space, which is going to be a focus of sort of my area of research, but many other areas of infection, including wounds, maybe sanctuary sites, more difficult to penetrate sites such as the central nervous system, can be challenging at times, and co-medications can make that even more challenging potentially. Enhanced renal elimination, I already mentioned that, augmented renal clearance, but on the opposite side of that spectrum, certainly reduced renal function and dynamic renal function, such as acute kidney injury, which is very rapidly changing in a number of individuals, can predispose to unpredictable drug concentrations, especially if we are, as we often do in practice, altering our dosing to achieve a certain percent reduction of your maintenance dose based on package insert. Maybe that might not necessarily reflect the true renal function that is happening in your patient in front of you. There's a significant number of individuals who have changes in their intravascular volume, either due to intravascular volume expansion or through capillary leak, fluid moving and shifting out from the vasculature into other spaces. And we can't forget about extracorporeal drug removal, either in terms of circuit binding for patients who are undergoing ECMO, as many pediatric patients do in the ICU, as well as through renal replacement therapies for patients who do have AKI. So there's a number of ways in which drug concentrations may become unpredictable and difficult to discern using sort of those population mean values. And the rationale, I think, for our group and why we're focusing on hospital-acquired pneumonia is that this is a very common infectious disease state that is plagued by continuous poor outcomes, as evidenced in recent clinical trials, where the response rates or failure to response is around 30%. 20 to 30% of patients will fail to respond to our antibiotic therapies. And again, being fairly common overall, with comorbidities, including acute kidney injury in the setting of pneumonia and sepsis, and a good number of these individuals concurrently also requiring renal replacement therapy, means that there's going to be those alterations that we just mentioned in the previous slide. When you put together the risk of mortality in these individuals who have both pneumonia, an infection that requires prompt treatment, rapid treatment to mitigate that mortality risk, as well as concurrent renal replacement therapy, a significant number of individuals are at risk for unfortunate mortality in this scenario. So this is certainly a significant problem that needs to be addressed. And as part of our preliminary work with the Northwestern University script investigators, we looked at blood concentrations in individuals. We looked specifically at plasma concentrations of meropenem, and just asked the question, based on what we showed you just a little while ago, that 100% time above MIC at the 1 times MIC or 4 times MIC level, what are we achieving? How often are we achieving or failing to achieve these goals? And how much variability actually exists among our patient population? So we had 70 individuals in this study. These were sparse. We collected samples. They were not collected specifically for a pharmacokinetic study. These were really plasma samples that were saved as part of the larger script study, and we performed pharmacokinetic analyses on these. And when you see sort of the distribution in this rain cloud plot, if you will, you can see that there are a number of individuals who are indeed achieving good time above MIC, no matter whether or not you define adequate as 100% or 1 time the MIC or 4 times the MIC. We still have a good number of individuals living in this domain, but similar to what we saw before, we see around 40 to 50% of individuals falling below this threshold and living out in this area here. So these are the individuals that we really think could benefit from dose individualization, supporting our overall study hypothesis. And so when we bring together our hypothesis about the need for dose optimization in patients with pneumonia, it really prompted us to try to define how we can do this in a more of a prospective manner and a prospective study. And so our current investigations, both in R01 and R21 funded investigations, are focusing on doing pharmacokinetic sampling in patients with pneumonia, and then linking these to site of infection. So what is actually happening within the alveolar space in patients with pneumonia? At Northwestern University, Dr. Wunderink is the lead investigator for the script study. And also, I think, still the medical director of the medical ICU. And so what we perform as a standard of care for a number of patients is bronchoscopy or non-bronchoscopic bronchoalveolar lavage. So instead of sort of upper respiratory tract specimens, we're looking at lower respiratory tract specimens, and usually of a very high quality in our patient population. And we have this unique collection of specimens from which we can garner quite a bit of information, not just about pharmacokinetics and pharmacodynamics, but about what's happening in the lung space at the cellular resolution as well. So there's quite a bit of detailed information about the lung biology that is emanating from this study. And so from a pharmacokinetic perspective, what we hypothesize is happening is that we have reduced time above MIC, reduced target attainment in the lung space, especially and most predominantly in patients with reduced time above MIC in the blood. And so that those two would then be linked pharmacokinetically. And then once we have defined that model that links what's happening in the lung with what's happening in the blood, we can then begin to form these models and create an adaptive feedback and control system, being our ultimate aim, so that we can then return to the patients going forward and use these models to better individualize drug exposure. So again, this is data that's emanating from the successful clinical response in pneumonia therapy study, which is U19 under Dr. Wunderink at Northwestern. And really, again, the unique advantage of our study is that the patients enrolled have a lot of bronchoscopic alveolar lavage, or BAL, fluid sampling, as well as plasma. And to this, we are adding intensive PK sampling in a subset of our patient population to really further develop and optimize our modeling to go beyond just sparse sampling. So when you look at sort of the overall design and what we're looking at, we know that 30 to 50% of patients are going to experience failure in pneumonia, and we will be measuring and modeling the blood and lung fluid concentrations, developing our pharmacokinetic models, and then beginning to start to look at the pharmacokinetics and pharmacodynamics in these patients, and trying to identify unique risk factors for treatment failure and failure to experience a good outcome in this population, be that inadequate time above MIC or other clinical risk factors as well. So in terms of our approach, we used a number of different methodologies. Primarily for meropenem, we quantitated meropenem in plasma and BAL using an LCMS assay. And for urea, we used an LCMS assay to quantitate sensitively within the lung fluid, the BAL fluid, and a commercially available assay for the plasma, given the differences in the concentration ranges. We evaluated multiple pharmacokinetic compartmental models, understanding, of course, that some parameters may not be potentially identifiable with sparse sampling, but we anticipate with richer sampling, we'll start to be able to quantitate and get a better estimate of some additional pharmacokinetic parameters. But certainly the two-compartment model was where we would start from, since we know and have measured concentrations in plasma as well as ELF. In terms of the timing of the samples and what existed in the SCRIPT study based on sort of random sampling and the timing of samples not collected specifically for a pharmacokinetic study, we found a number of different sample pairs that sort of followed different scenarios. So a common scenario, the most common scenario that we saw was that a dose was received by a patient, and then they had some plasma sample that was collected, usually a morning lab plasma, and then followed up with some ELF or BAL, which we translated into epithelial lining fluid sampling later on in the course of their dosing interval. So that was by far and away the most common scenario. A less common scenario was that a dose was given and then the BAL was performed and an ELF sample prior to the plasma. And then a less common scenario was that there was a dose and an ELF sample available, but the plasma that would have the urea in that plasma sample for our ELF to plasma ratio, that it just fell before the dose. So that would be a scenario where we couldn't use the plasma sample to inform plasma pharmacokinetics, but it certainly did help us with ELF as well. We see that for our cohort of patients, we went from those 70 individuals originally down to 67. Again, there were a few folks who didn't have or had BLQ samples, and we weren't able to use those samples for either the ELF or the plasma. But among individuals who did have contributory sampling, we saw that the average age here, not unexpected, is a little bit older, 57. A range of 40 to almost 207 kilograms, so a very wide range in body weights among adult patients. we saw that the creatinine clearance was estimated by Cockcroft and Galt methodology, and we see quite a wide range in serum creatinines, with a number of these high serum creatinines being driven by very low serum creatinines of around 0.2, high creatinine clearance. We see that ECMO was relatively prevalent, around 23% of our patient population, and renal replacement, we saw around 2% of these individuals at baseline. But this obviously is a dynamic variable and can change throughout the course of their dosing. When we look at the types of the sparse samples available, we see plasma in blue here and ELF fluid in red. And we see that we had certainly a little bit more plasma than ELF sampling available. And this was, I think, more fully described in our recent publication of this preliminary data. But what I want to show you and highlight are the different methodologies that can be applied to this data. We chose, based on sort of our experience, to use a non-parametric methodology. But certainly, our methodology we could also use a parametric approach to estimate the pharmacokinetic parameters. And this is really the results of the same, more or less same structural model being applied to the same data set and coming up with a distribution under the parametric approach using monoliths. And you can see here the distribution that was estimated for the central volume as well as the primary creatinine clearance driven clearance. And then we also estimated a power coefficient onto that creatinine clearance, knowing that that's not going to be a fully linear relationship when we have creatinine clearances that range so widely. On the other hand, you can see what the non-parametric model produces. So the main difference, again, is sort of the density of the parameter estimates within the population here and monoliths. And the non-parametric approach, you have what are called support points. These are discrete probabilities. It's a joint probability of having the parameter value assigned. And certainly this could be up to one support point per individual in the sample. But this can also be condensed down by the non-parametric adaptive grid algorithm. And this is something that's come out of the lab of Roger Jelliff and Michael Neely over a number of years. And so when we look at the comparison between the model fits using more or less the same structural model and fit using a parametric and non-parametric approach, we see overall not a huge difference in terms of the actual predictions between these two methodologies within the population, either for plasma or ELF. Some minor differences, but overall reasonably good R-squareds. We're seeing a little bit lower with ELF than we are with the plasma, certainly because we only have one concentration, usually one concentration per patient per occasion. And we see within the plasma and ELF individual fits, certainly a little bit tighter R-squared with the non-parametric approach. Some of this may be, again, because of the differences in the fitting and the likelihoods associated with the non-parametric approach versus what monoliths defined. But again, what we see is that there's reasonable concordance, and we think we have a reasonable pharmacokinetic model using either approach, truly. Under the visual predictive checks for these models, we sort of see that this is, again, a simulation-based model diagnostic for the non-parametric model. And our quartiles are reasonably well separated, except for perhaps at the very beginning and very end of sampling in our plasma. And that is highly driven by the fact that there was limited samples early and late when we look at time after dose. And a similar story can be found here for ELF as well. So the majority of the sampling happening sort of randomly between the beginning of the dosing interval and the end of the dosing interval. When we look at the results using monoliths, those are very similar. I think a very similar story shown, perhaps a little bit less sample intensity available for the ELF around 3.5 hours time after dose, but not necessarily highly different. So when we look at how can this be translated, we're kind of going back to the very beginning of our presentation, and how can we then use these models and start to begin to translate them to patients to improve our dosing. So if we accept that the model estimate, non-parametric or parametric, is going to be a useful model, we would need to certainly validate that externally before applying that to patient care. This is an example of 2 additional script patients that have been enrolled. Their plasma was actually analyzed at the Northwestern Memorial Hospital laboratory as part of our routine TDM now that we are performing for these patients. So we have standard of care TDM that we brought in-house. We're being able to quantitate piperacillin, meropenem, and cefepime in the blood of these patients. And this is really driven by protocol and the discretion of the pharmacist and the treating team. And so these samples were obtained not by me, but by my colleagues who felt that these individuals needed to receive TDM. What we see in blue is the population model support points. So we sort of flash back to the population model that I showed you with those individual support points. And we can see here again the distribution in blue, as well over here for clearance, the distribution in blue. And the red here are 2 individuals who were not included in the original model development. And we can see the distribution of their support points as fit using a Bayesian approach. So we used a Bayesian approach to use the model as the prior, and then we applied that model to the samples of these patients and came up with a distribution of support points that was more likely for these 2 individuals. And we can see how those distributions are very similar. The active support points are of a similar distribution in general to the population model. So the population model is informing the predictions to a large extent. And that's likely because we're only getting 1 to 2 samples for our patients as part of our TDM protocol. But what is achievable? We can see here that if this is sort of the beginning, if you will, of an external validation procedure, what we see is that this is the model is useful certainly at getting these midpoint concentrations reasonably well. We're fairly close on both of these patients, maybe missing a little bit on the high end for the Cmax. And I think what we see is that this model that we have preliminarily developed is something that we're going to continue to refine and integrate additional data. We have a number of patients just awaiting sample analysis, and we're excited to begin that work of analyzing more and more of the samples that are available from script and our prospective R01 and R21 studies, focusing on patients with and without renal replacement therapy. And so at this juncture, what I'd like to do is just acknowledge the extremely talented co-investigators, the script PI, Rich Wonderink, as well as Alan Hauser, who's the PI of a sub-project in script, Project 2, Mark Sheets, who's our lead for assay work here at Midwestern University, Michael Neely, who's been very instrumental in helping to maintain Pmetrics, which is the non-parametric program that I've shown you today. Egan Ozer, again, a colleague of Alan's, responsible for helping us with the genomic analysis of isolates coming from script, as well as Paul Yarnold, our lead statistician. The entire Northwestern University script investigator team, which is tremendous and huge. They have a wonderful group of investigators there who are doing excellent work. Within our laboratory, Dr. Roxane Rohane really took the lead on developing our methodologies for quantitation of meropenem and urea, and I'm very excited for her. She is now faculty at Rosalind Franklin University within their College of Medicine. Kay Dedicatoria, recent pharmacy student who is now graduated and practicing. We're very excited for her to be pursuing residency, acknowledging all of my funding and all of my mentors and colleagues, past, present, and our wonderful institutions. So with that, I will conclude this part of the presentation, and thank you for your time and attention.
Thank you very much. I had a couple of questions. So firstly, I was thinking about like Beta-Lactam is resistant, probably give your thoughts on what are some approaches with which we can tackle that using, pharmacokinetic modeling.
That's an excellent question. Antibiotic resistance certainly is a huge public health problem. The way that we handle this clinically is we target and attempt to target our dose individualization in patients that we're doing therapeutic monitoring on to achieve certain targets that we believe are sufficient to treat the infection. If the house is already on fire, throwing a glass of water on it might not help. So we do try to avoid using agents that are certainly resistant. I think if we pushed our doses too high, we're going to induce that toxicity in our patient population. So the pharmacokinetic modeling, I think, for one agent with a higher MIC is useful to a point. But then you start to, I think, lose the activity of the agent at the expense of excessive toxicity to the patient. So at that juncture, we would certainly recommend, and our protocols do recommend, consultation with the ID pharmacist, as well as having a discussion about changing agents when you're looking at inability to achieve reasonable targets with reasonable safety. That is our recommendation. When it comes to the dynamic side, and this is really, we've set the stage for the pharmacokinetics. We're really beginning to shape this in pneumonia. For the dynamics, I think we need to look at this very carefully, and there will be more data emanating soon. The lung is a very interesting organ to study, especially the alveolar space. There's a lot happening there. And I think more to come as we begin to start to peel back the onion of what is achievable in terms of pharmacodynamics.
Thank you. Another question that I had when you mentioned like the need for therapeutic monitoring and how we use certain factors to determine whether there is a need for therapeutic monitoring. And this is just something that I was curious about. So I saw that there was the altered penetration at infection site, which is one of the factors. And I was just curious to know like how that is usually assessed, like how that's usually assessed.
It's a great question. From a clinical perspective, alterations at the target site are a bit of a black box under most circumstances. We've started to try to push forward our assays at the hospital for both the blood, which is, I think, relatively easy compartment to measure, as well as the CSF. We are in talks to continue to develop clinical assays, not just for research only, but clinical assays for the lung as well, which again, as I kind of showed you, involves a lot of different assays concurrently. It's a little bit more challenging, but not all lungs are the same. So certainly a patient with ARDS is going to have a different overall lung physiology, and the cellular structure and the blood flow to the lung is going to be very different from a patient who's coming in and develops a little pneumonia, a little bit of inflammation, and then kind of bounces back very quickly. So there are different phenotypes within the patient that are going to drive some of the ability of drugs to cross membranes. What I didn't show you was sort of the lung penetration that we observed within our patient populations empirically. So we were able to compare the AUC of drug, meropenem, within both the blood and the lung. And what we saw was that there was actually slightly higher penetration than what had been documented previously with meropenem. Numbers, for the central tendency sort of range from around 25% penetration to upwards of maybe 30, 35%. We got something a little bit closer to 40 to 50. When we looked at that, we believe that that is a function of our patient population and, again, sort of the level of severity of illness that we're seeing in these individuals. So perhaps they have higher breakdown of the barriers within the lung space. But again, how you perform BAL, the quality of the BAL does drive a lot of what we're going to see with the penetration as well, and the actual physiologic compartment that you're sampling. So I think it's important to know, does your methodology, does your assay actually have sort of what you want it to have in terms of performance? Is it sensitive enough, well calibrated for what you want to measure? And then B, is the sampling quality appropriate for what you want to measure? But going back to, I think, your original question, how do we deal with this in clinical practice? I think most clinicians will use sort of averages and sort of make inferences based on those averages, or rely on folks like yourself and myself to do Monte Carlo simulation, to do model-based simulations to come up with regimens that should achieve what we say they're going to achieve in the population. And I guess the heart and soul of the research program that we're developing is that while those approaches are useful and informative, they may not capture the tails. They may not capture the upper 10%. They may not capture the lower 10% of your population. And so we need to be looking very carefully at the outliers.
Thank you very much, Dr. Rhodes.
Hi, this is we got a few questions here in the rooms, so I wonder if we could maybe transition to that. So this is Rob Bees, University of Buffalo. Jim, I thought really interesting presentation. So I had a couple of questions. Okay. Oh, I see. Is it a recording, or is he available for questions?
I'm here.
Okay, great, wonderful. Okay, so I saw I had a question, but sort of related to the target achievement. You showed this was 4 times MIC. In your practice, have you been able to establish a correlation with the patients that achieve those targets and an improved probability of success in terms of the resolution of the infection?
Thank you so much. And again, it's my pleasure to be available here. Unfortunately, I'm not available to be in person, but this is an excellent question. And I will tell you, it's actually a very difficult question to answer with certainty and with clarity. We are still looking at this within Script with our collaborators. The challenge is, of course, the disease and the timeline and the comorbidities that patients have. So with renal replacement, increasing mortality risk, that's going to drive drug concentrations high. And you will sort of see that concomitant risk of mortality driving outcomes. So we need to look carefully at those data to make sure that we're avoiding paradoxical confounding. Right? Because if you sort of find an association where higher exposures drive worse outcomes, is that true, or is that an artifact of what's causing the patient's illness, right? So the severity of their disease and their predisposition. So
Sure. So it sounds like your concentration
data,
control would answer that, right? So you would target it, you get more people in that group, and then you could actually make that comparison much more directly, I guess.
Yeah, absolutely. So
But,
if we could do that, that would be ideal state. We are at the very beginning of this implementation of therapeutic drug monitoring, and so I'm optimistic that we can actually start to answer that question in a more prospective manner.
One more quick question: what is your sense of the relative level of determination or over-determination using this non-parametric adaptive grid approach with all the support points for a relatively small number of individuals?
Yeah, so I think your question is, how confident can we be in sort of the model estimates? I think that, sparse sampling is always a little bit challenging to make strong inference based on. At the same time, we can compare to known values, we can compare to the literature. What we've seen is that our estimates seem to be fairly in line with central tendencies from some other models. I think we showed you in some of our initial external validation work that we're missing in a few spots in terms of being able to recapitulate the Cmax for making an evaluation of time above MIC that may not be critical. But at the same time, we want to try to generate the best model that we can in order to inform practice in the future. So we're going to be going through that refinement process, and I'm excited to see what the data from our more rich sampling will tell us once we start to integrate that in.
Yeah, Stefan Schmidt, University of Florida. A very nice presentation. I have a couple of questions regarding the PK/PD indices that you use, because it seems to me that you're putting all your eggs in the pharmacokinetic basket. And so basically, 20, 30, 40% in PK is driving whatever outcome you have. As far as I'm aware, when you measure the MIC, you have like an innate twofold variability in the measurement. So it may be, 1, it may be 0.5, it may be 2. And so by definition, I mean, that changes the probability of what you're predicting quite a bit. So that's number one. Number two is that it seems that the predictions would hold if PK and PD are on the same time scale. So if you have, a short half-life drug, within 24 hours, and then the bug turns over also fairly quickly, that oftentimes, holds true for pneumonia or Staph aureus, but it falls apart when you look at tuberculosis, where basically the doubling time or the susceptibility of the organism over time basically drives your response. Number three is, some of the PK/PD indices are heavily focused towards efficacy, and azithromycin is, for example, a fantastic example for that. If you have a long half-life drug and you fall below the MIC, you also stay there for a very long period of time. And so then you have basically the inverse mutational frequency is then basically relative to the half-life, determining your emergence of resistance. Could you maybe comment on these aspects?
Okay, very good questions. Thank you so much, Stefan. So first question, I'm going to try to remember it very carefully, but MIC variability, we have not yet fully integrated MIC variability. We showed you in the preliminary data from the 70 individuals, sort of the empirical targets, and that was driven by our observed MICs for our patient population. In our subsequent analyses, we've really focused on the pharmacokinetics, and we've done some simulations based on sort of breakpoint MICs. So that would sort of be a worst case scenario clinically. Certainly doubling dilution up or down based on what you see in the clinical lab is very much an important point, because you can see that variability in the MIC. Certainly, I think we could potentially integrate some noise in our simulations to address that level of uncertainty. But you are absolutely correct that that is an underappreciated phenomenon in the clinical lab. When we're conducting our MICs, we're trying to attain broth microdilution on the isolates that we're garnering from patients in our study to try to improve our reliability of the MIC, but definitely agree that MIC variation is very important. The next question I think that you had, part two, was the time course and the relevance of some of these indices in infections where the turnover rate is high versus low, tuberculosis versus sort of your simple bacterial infections. And I think that was really an area that you wanted maybe some comment on the nuance. And I'm not a tuberculosis expert. I know that you have some experts there at the University of Florida. We see patients with TB on occasion for sure. What I would say is that I would agree that the time course is important. And that's partly why we have combination chemotherapy in tuberculosis, as well as longer durations of treatment, certainly. But in terms of establishing indices, it can certainly be, I think, a little bit easier to do that in the setting of when those indices are linked up with what you're seeing with outcomes. So it's a very fair point versus that disconnect that you see in tuberculosis. And the last point that you had was in relation to sub-MIC concentrations of maybe drugs with long half-lives. And maybe you could provide just a little bit more clarity on what you were hoping I could comment on for that one.
Um, so sorry, I actually forgot the third part of my question.
No,
I'm sorry
no
about
worries,
this.
no worries. But I agree that you know, for beta-lactams, these are short half-life drugs.
Oh yeah.
With carbapenems, you know, there are since this is sort of the focus of this, you know, there's that a little bit of a post-antibiotic effect,
Yeah.
and they are primarily working within the periplasmic space, whereas macrolides are intracellular drugs and require integration inside the cell.
Yeah, so I guess what I was asking, I remember, thank you for comment, is like you need to pay attention to some of that tail that you have. So once concentrations drop below the MIC, and so then it depends, you know, how long they stay there. I guess that's one of the reasons why we're no longer using DDT in agriculture, because you want the drug to do the effect and then be gone, so to not be, you know, triggering resistance.
Absolutely. Very fair point. Thank you so much.
Last question.
Wojciech Krzyzanski from the University of Buffalo. So I have a question regarding the performance of these non-compartmental, non-parametric models that you have versus those parametric models. In terms of the running times and convergence, can you comment about, you know, comparing those to those parametric models? Were there longer running times and the issues with convergence, things like that?
Very good technical question. Thank you so much. The non-parametric model that we showed you was parameterized with differential equations, which generally takes longer to run than a comparable run with monolix. So the run times can be longer. Convergence is also evaluated with the non-parametric approach, and our models did converge. Based on the likelihood functions and the estimates that were produced. But it is a very fair point that those runtimes can be quite long. It's computationally intense. And as we start to expand, certainly the number of parameters that we're trying to simultaneously estimate, we can start to run into some difficulties. And so that's why we try to be you know, physiologically oriented when we're conducting our modeling and look at the most important physiologic drivers that we know based on the literature. These molecules have been around for a number of years, right? And a lot of the great foundational work has been done by industry and pharmaceutical industry. So we know that creatinine clearance, for example, is an important driver of drug elimination, and body weight is usually a very important driver of disposition. So we have the advantage of doing that, and then we can then layer in on top of that other important explanatory covariates that are unique to the ICU, like renal replacement and extracorporeal membrane oxygenation, things along those lines. But very much a longer runtime. We have taken into our practice in modeling, doing maybe some initial estimations using Monolix or another program that has a shorter runtime to inform sort of our best guesses towards the parameter ranges we should be looking at with the non-parametric approach, just to avoid excessive amounts of model development, kind of shortening that lead time on the model development side. Thank you very much.
Thank you.
All right. Thank you, everyone. Sorry, Dr. Baez, I didn't let you ask your question for a long time, but yeah. Yeah, we're going to have a break now, and we'll be coming back at 10:40. So yeah.